So I do come from Rome, so I really look forward to the opportunity to have you in Rome. And this is Sapienza University, and we will surely enjoy our educational and leisure time in Rome next year. This topic will focus more on coronary artery disease and acute coronary syndromes. There will be some overlap with the prior presentations, but this is welcome in order to emphasize what is most important from the last ESC Congress. So this is a study which was performed in Europe, which compared in Sweden in particular, which compared the time before and after the adoption of a high sensitivity troponin assay in coronary care units in Sweden, and focusing on whether the use of this assay was associated with a difference in the way patients were labeled and diagnosed after the acute event. Basically, this period 1 was before the assay was available, period 2 afterwards, and so we can see that the number of patients who got a diagnosis of myocardial infarction increased, and the number of patients with a diagnosis of other conditions decreased. So this registry, nationwide data from a country with a very high standard in terms of healthcare quality, suggests that these high sensitivity troponin assays are beneficial in the workup of suspected acute coronary syndromes. Still on troponin, this study from Germany, the BECT trial, focused on 1,000 patients with chest pain suggestive of MI, and basically it used high sensitivity troponin T in this case, and an I, but using different cutoffs, and especially a 1 hour rule approach, basically using the troponin after 1 hour to make a decision or mock a decision. And the results were very reassuring in the sense that the 1 hour rule out approach using a 6 nanogram per liter cutoff was safe and effective, and enabled the timely and efficient stratification of patients with suspected MI. Professor Ferrari has already highlighted the importance of focusing on acute myocardial infarction beyond what is mechanically done. So we have come a long way in terms of stenting, of balloon, and so forth. Also, antithrombotic therapy is rather refined today. What is missing probably is how we can improve reperfusion, in the sense that if we do not reperfuse at all, we know that the infarct size is really extensive, up to 70%, high risk of death, unfavorable modeling, mechanical complications. But if we do achieve reperfusion, we still have some issues in the sense that the reperfusion itself, in the way we do it today, might be detrimental, at least in part. And we may possibly, in humans, definitely in the animal model, improve the results by modulating reperfusion injury and the pathways which are activated by reperfusion, and possibly fulfilling the prophecy and the promise of reperfusing a heart and protecting it from what might be detrimental in terms of oxygen effects, radicals, and so forth. And as we've seen presented by Professor Ferrari, there was a big hope on cyclosporine, so on the immunomodulation of reperfusion injury, thanks to this small but very, very favorable trial which was published a number of years ago in the New England Journal of Medicine, suggesting that cyclosporine in patients undergoing PCI for STEMI was associated with significant benefits in terms of CK release, which might be a surrogate for adverse remodeling. So the French cardiology group at large has performed the circuit trial, we've seen much more larger sample, almost 800 patients. Unfortunately, this trial, as shown by Professor Ferrari, was largely negative. So no difference in clinical outcomes, no difference in ejection fraction, no different either in CK release. So this approach is not necessarily effective, despite that it is reasonably safe, it's not detrimental, and that's already something we didn't actually knew. Focusing more on antithrombotic therapy, the TIMI group presented updated data from the TIMI 54 Pegasus trial, which is a large trial, 20,000 patients, comparing ticagrelor versus plus aspirin versus aspirin mainly long after MI, at least 1 year or even later on, and using, and this is the novelty, a standard dose of ticagrelor or a lower dose, 60 milligrams BSD of ticagrelor. And the trial was very interesting. It has been presented already in the past, but the ESC was enlightened by novelties in terms of the appraisal of the interaction between when the patient had the myocardial infarction and when the APT had been interrupted, and the subsequent benefits of ticagrelor, showing clearly that if we do switch to ticagrelor, or if we could continue ticagrelor rather than stopping and then waiting many months or even more than 1 year, we have much greater benefits. So again, to see the details, we have much better results in terms of adverse events, because the risk is much higher shortly after P2Y12 inhibitors have been discontinued in terms of cardiovascular death and mild stroke, in terms of cardiovascular death, in terms of MI, and most likely also in terms of stroke. And as you can see, the benefits of ticagrelor long-term after MI were much stronger in patients who had recently discontinued P2Y12 inhibitors, suggesting though that we should not discontinue them, and in patients who are candidate to a Pegasus-like treatment, then we should probably either switch to ticagrelor or continue with ticagrelor, albeit possibly at a lower dose, and obtain the benefits suggested by the trial, which convinced actually the FDA. And these are the Kaplan-Meier curves. As you can see, 90 milligrams might be a little bit better, but this is debatable. The point is, this is a very long-term trial, almost 3 years of follow-up, and as you can see, the curves continue to separate, suggesting that every month that the patient is continuing ticagrelor therapy is going to be beneficial for the risk of major adverse cardiac events, especially if ticagrelor had been instituted shortly afterwards or without any interaction of the APT. There was also a pooled analysis presented at the ESC from the Canadian group of a number of trials on prolonged dual antiplatelet therapy following myocardial infarction, and these are mainly the APT trial itself, but also the Pegasus, the Desolate, Arctic Interruption, Prodigy from Ferrara, and Charisma. And the detailed analysis suggested that in these patients, continue something else as well is going to be highly beneficial in terms of a reduced risk of MACE, in terms of a reduced risk of cardiovascular death, reduced risk of myocardial infarction, reduced risk of stroke as well, and of course, reduced risk of stent thrombosis. We do expect, though, to have an increase in major bleeding and similar all-cause death rates. So if we can identify patients who are at high risk of thrombotic complications, but not at prohibitive risk of bleeding, then probably prolonged APT after myocardial infarction is reasonable with either clopidogrel or possibly low-dose ticagrelor. This trial was an old trial which showed that confirmed the RAISE trial in the setting of acute MI, and so confirmed the case that mineralocorticoid receptor antagonist is a reasonable strategy in heart failure and acute MI, as shown by Professor Ferrari as well. The Albatross trial tried to see whether these benefits can be achieved even shortly after a STEMI or STEMI by instituting therapy very early on, so in the first 72 hours after the acute event. Unfortunately, the results were not in favor of this strategy, so despite the fact that we do know that MRA therapy is beneficial in patients with acute myocardial infarction or heart failure, there is probably no need to rush with this treatment and start this early on in the acute phase of an acute coronary syndrome. So to conclude and leave some room for discussion, the main messages in terms of coronary disease and acute coronary syndromes from ESC were on ME diagnosis, STEMI treatment, and secondary prevention. In terms of myocardial infarction diagnosis, we have seen that high sensitivity troponin measurement has improved the detection of acute myocardial infarction in the real world nationwide, and that a 1 hour rule-in, rule-out strategy with a high sensitivity troponin test will probably be the dominant strategy in the near future because of effectiveness, efficiency, and safety. In terms of STEMI treatment, cyclosporine unfortunately was not significantly beneficial in STEMI. Nonetheless, we might argue that different conditions between study groups might have had an impact on the results, as well as different formulations in comparison to the prior data. We do need further trials aiming at reducing reperfusion injury, maybe with different anti-inflammatory formulation. For instance, there are groups working on anti-IL-1 treatments and so forth. In addition, we know that acute treatment with the MRA is not impactful in STEMI or non-STEMI, despite some hints that in STEMI you might have an effect, but this probably requires further corroboration. In secondary prevention, we have seen that patients with high ischemic risk benefit significantly from prolongation with of the APT with the ticagrelor, especially in a specific setting of short-term withdrawal in terms of short amount of time passed from the discontinuation of P2Y12 inhibitors. Conversely, long after this event has occurred, probably the benefit is smaller and might not offset the risks of this treatment. And finally, prolonged APT seems to be beneficial and reasonably safe in high-risk patients. Thanks.